Okay, welcome everyone to this SDSMA Center for Physician Resources presentation, Standing MACRA, the Quality Performance category. This presentation is brought to you in partnership with Avera Health and the South Dakota Center for Advancement of Health Information Technology, or KHIT. This is our third of 4 programs that we are doing dedicated to understanding MACRA. And we're going to try to keep all phone lines open so you can be interactive with the presentation and to ask questions. However, we do pick up a bunch of background noise. I will go ahead and mute lines, and then we'll stop throughout the presentation to provide an opportunity to ask questions. And with that, I'm going to turn the presentation over to Dan Frederick of KHIT. Dan is Executive Director of KHIT, and he is a Certified Information Systems Security Professional. He has more than 30 years of experience in information assurance and adult technical instruction. And at this time, I'm going to ask Dan to further introduce himself and then lead us through this discussion. Take it away, Dan.
Thanks, and I appreciate the opportunity to visit on this topic. I know it's the holiday season, so we'll try to stay right on time. Might even get done a few minutes early, but this is one of the areas where I think there isn't much of a change for physicians that are used to do PQRS, but there are a few nuances that I think we'll talk through on the quality performance category. So, as Mark said, I'm the director here at Center for Advancement of Health IT and for the Regional Extension Center from 2010 to 2016, and we are now on contract for the Transforming Clinical Practices Initiative. So if you need any assistance with this or a little more detail or clarity, certainly feel free to call us and we'll step you through this. So that, we'll just go ahead and get started. I'll get started. There we go. So during this session, as Mark said, this is the third of 4 sessions. Next session will be wrap up, and we'll be doing some scoring things. But tonight we really want to focus on the quality act of the MACRA MIPS legislation. So we'll look at a few of the key changes between MACRA and what you might be used to with PQRS. We'll spend a bit of time on how you can submit data through MIPS, even though that hasn't been finalized as of yet. There are a lot of options on the table, so we'll spend a little time with that. We'll look at the performance category itself and how that scoring will roll out. It's about 6/10 of the total score for this initial year, so it really is a big part of what it's going to take for MIPS to score well and get into those incentive dollars. And then finally, we'll have, it won't be a solid checklist, but it'll be a number of things that you can do to get prepared, because the deadlines are looming, if you will. You know, there is some flexibility this first year, but if you want to do full year reporting, that starts right away in January. So if on your radar to get started with the full year reporting, then you're going to have to be ready to go pretty quick. So the first few slides here, if you've been on the other earlier sessions, I'll apologize. You'll have seen these a couple of different times, but there might be a few new people on. We'll go through them pretty quick because I want to get to the meat of the quality piece here. So, you know, this program, if you look at the money that CMS has sunk into getting prepared for this transition, you know, it's millions of dollars. You know, the Meaningful Use Incentive Program and the Regional Extension Center Program upwards of $20 million. There's a ton of money coming into it via this practice transformation networks. So CMS has really spent a lot of money on this, and they're kind of approaching it in a little bit different way than they have in the past. They are taking a lot of input on it. Even the final rule has some room still for comment. So if you find something in the final rule that doesn't ring true for you, or you get comments into CMS, we're on a lot of national calls, and they're iterating that to us, is they're trying to get as much feedback on this as they can get because they understand what a massive switch this is for people. So they are starting to look at it as it really is a fresh start for how we're going to pay providers in the future, and they want to make sure that they're trying to be as user-centric and flexible about this beginning process as they can. So as we work through the slides, I'll pause just for a few seconds at every new slide. So if you have a question on any of them, that's a good time for you to jump in. I won't pause for too long, so if you got a question, feel free to jump right in. Who's going to participate in MIPS? That's really Social Security Administration's definitions of providers. And if you look at years 1 and 2, they're doing physicians, physician assistants, nurse practitioners, specialists, and nurses, anesthetists, sorry. And so when we think about Social Security Administration's definition, right, you know, we're talking about the ones here at the bottom: MDs, DOs, podiatrists, optometrists, dentists, and for certain procedures that chiropractors perform, it also applies to them. And then after these first couple of years, we're going to start with this core group of providers. Then they're going to bring on the other folks. They're going to bring on PT and OT and speech pathologists and audiologists and another whole set of provider types. So ultimately, by the time you get out to 2022 to 2023, all providers that are getting paid through Medicare will be to MIPS participation or being an alternative payment model. There's some exceptions and some places where you fall out of the curve, so to speak. First is if it's your first year in Medicare Part B, and I should mention that MIPS is applicable to Medicare Part B payments only. So this happens to be your first year in Medicare Part B participation. You would not be subject to MIPS. You would go by the physician fee schedule just like in the past. If you have a very low patient volume threshold, in that you're charging either $30,000 a year or under, or if you're providing care for less than 100 patients, you fall out of MIPS. You'll see that actually if you've been listening to other webinars, you see it presented a lot of different ways. So the rule is you're subject to MIPS if you have $30,000 billed and have 101 or more patients. So that's the and side. You'll fall out if either one of the things aren't met, either one of the conditions. So if you have under 30,000 or 100 or fewer Medicare patients, you'll fall out and not be subject to MIPS. That final category is if you're in one of the advanced alternative payment models, and there are several of them out there and available. There's not a lot of participation in those advanced models here in South Dakota, so it's likely that you'll meet that exclusion at this point. So when this is going to roll out in terms of time, 2017, it's going to be just like PQRS in that the payment adjustment years are going to lag behind the performance years by 2. So in 2017, you'll be measuring for that time period, and for 2017 only, there's a special shortened time period that's going to be 90 days. So the actual last date that you could begin would be October 2nd of 2017 to fit within that 90-day calendar period. There are some other options, and we'll talk about those as we get into it a little bit more. But the reporting period is 2017, calendar year 2017, and by March, end of March of 2018, you have to have your data submitted for that 2017 period. All the rest of 2018 will be a time when Medicare will be providing feedback And this is one of the reasons why we are recommending that providers, even if they're excluded from MIPS, current may want to do it to get that feedback. Because if you're excluded from MIPS in the 2017 year, it's kind of a no harm, no foul. You will have some time in it, but you can be assured that as more and more commercial payers are also going to follow suit. In fact, they're doing some things with Comprehensive Primary Care Plus. We're already starting to test these various models in the private sector. So if you can do it, I would certainly recommend trying to start in 2017, and there's a lot of reasons for that. One of the biggest reasons is CMS is still trying to figure out their way through this, and I believe they'll probably be a little more lenient in these early years than they may be after they get things set in place. So good time to get in on the ground floor of it. 2019, after that feedback year, 2018 comes around, then your Part B payments will be modified based on how you performed in 2017. So modification is going to look different. If you look at kind of the bottom set of numbers here, 2019, that could be an 8% swing, all the way from 4% penalty to 4% incentives, and then that graduates upwards to what potentially is an 18% swing by 2022. That's based on the performance year of 2020, so that is coming relatively quickly in terms of this it's going to take in order to get there. So that's a huge swing based on value care instead of volume care. Timeline. Into a little more of the quality piece of this, and one of the reasons why I want to emphasize the quality piece and why tonight's is kind of an important session is because it's such a big part of it. For the 2017 year, you can see that the quality piece is 60% of your overall score. Your composite score is 100, and quality is 60% of that. In fact, there's even some exclusions and some methods where the improvement activities gets bumped up some and the quality activities get bumped up some if you have exclusions from advancing care information. So you could at least potentially be exempt from doing advancing care information. In that case, you'd get 0% for that category. Quality would go up to 75% and improvement activities to 25%. So it could have an even higher weight than the 60%, depending on some other factors that you might run into as an individual provider or as an organization. So we look at that. It's going to graduate over time. Once you get out to 2021, one of the things you'll notice is that the smaller pie chart in the right has 4 categories instead of just 3, and that's because the cost modifier has been left out of the 2017 year. So as this ramps up the effort, they left the value modifier out, and that will be, from everything we've been hearing, they're talking about just being 2017 as a transition year. So the value piece will be back in 2018. It won't be at this 30%. Eventually, the will be 30% and value will be 30% with the advance in care information, or what's to be meaningful use, as 25%, and improvement activities is 15%. So as you can see, over time, there's going to be a continual shift, not only to quality, but the value that quality brings. So as you get out there into those later years of the program, then you start to really see where the value and quality has a big effect on your payment. So 2017, just 2017 here, and we begin to start talking about how the quality piece gets measured. Is a replacement for PQRS and also the quality portion of the value modifier. If you were in the VBM program, that value modifier, that had a quality portion and a value portion, and this performance quality category places both PQRS and that quality portion of the value modifier. So I get that as 60% of the final score, and we'll get into some scoring things here in a couple of slides. But what you need to know really is that it's a big chunk, right? And we'll get that big chunk by selecting 6 measures. There's about 300 of them available to you, and we're going to look at those in just maybe minutes or so. I'm going to take you through the website, so a place where you can go and take a look at, think about which ones of these measures make a lot of sense for your organization or for you as an individual provider. But you need to select 6 of those, and now I'm sort of speaking for the vast majority of what I believe the listeners are, and that would be in small practices, under 25 providers, probably under 15, probably under 10, quite honestly. But so the majority of providers that fall under those 15 or fewer provider in an organization will select 6 quality measures out of this group. And one of those has to be an outcome measure as opposed to all process measures. So you'll need to have at least one outcome measure, and broke those quality metrics down into low priority and high priority. So you would do a process measure if it was in fact a high priority measure, and I'll show you how they've defined those here in a couple of minutes when we go look at it. So there are different reporting requirements for those organizations that have over 25 practitioners that are currently using the CMS web interface. If you're doing that and you're doing your claims and things via the web interface, you have some additional quality metrics actually. The number goes from 6 to 15. So the thing is, if you're a large enough organization to be using the web interface, you probably have more quality measures already being recorded, tracked, as it were. So now they did break down a lot of measure sets into specialty groups. The numbers still say the same though, right? If there are 15 specialty measures, you still only have to do 6 of them. So there's final, and I'll call it sort of a special metric. If you are in a larger group, say over 15 or 16 or higher of clinicians, and you have a sufficient number of cases, which in their case it's 200 cases, then they'll also be measuring you on your readmission rate, your PD readmission rate. Now there's no reporting for that because it all comes off the claims data. So you won't have to measure that, or you won't have to read that, but just be aware that you will be measured on that if you're in that larger group category and you have over 200 cases. So they look like, I'm actually going to go there. When you get the slides, and the Medical Association will have the slides posted up on their site, and as well as a copy of the presentation. So I would definitely recommend getting a copy of these slides because this is a live link in those slides, and you can jump right out to that from here if you don't want to write down the slides. It's actually fairly easy to get to. It's QPP for Quality Payment Program, CMS.gov. So now, and you can see that it's fairly interactive when you get out to this site. And again, this is qpp.cms.gov, measures quality. You can go along and you can select the measures based on keywords if you want to search for specific things. You can also filter them, and this is where I think it's probably the nice component of this, is being able to filter by different things. So, for example, we start out with a set of 271 measures. Really only interested at this point in the high priority measures. You know, that cuts us down to 168. You may want to look at, I only want to find things that they can hear from claims data, so that brings us down to 42 measures. You may be a pediatrician, so that's actually down to 2 measures, right? So you wouldn't be able to do this as a pediatrician. It's likely the data submission. If you could submit via HR, you'd be. If you could submit through a registry and an EHR, you could do up to 7. So you'll have to some opportunity here before the year starts to sort of look at how you can submit the maximum number, because you need to submit at least 6. So if you're in a specialty measure set like pediatrics, you'll need to see how you can submit if you want to do high priority measures. If you want to do both, then of course if you got some low priority measures that you can utilize as well. That gives you a little more flexibility. But filtering works pretty good in here. The thing that you can look at while you're in here looking at these various measures, if you click on the measures, it shows the NQF number or the CMS number, what's a high priority, what the data submission methods are, ways that you can tell CMS you're doing this, right? And then what specialty measurement set it falls under. So you can go that route too. Now keep in mind, this is a process measure, not an outcomes measure, and you have to have at least one outcomes measure. So you'll want to keep that in mind as you go through. So if we clear all the filters, we're back to that 271. One of these things that you can do in here is you can add measures. Just select 2 or 3 of them, and then gives you the ability to download those into a comma separated value or Excel format. If you're out on the website, you find some that you think will work for you, definitely you can put them over into the selected measures category. And none of this stuff, the little yellow box on here, shows that this is only for informational and estimation purposes. This is not how you submit or attest to doing these. So this is purely educational. You can't do anything wrong in here. You can go in, you can add, remove, you can take them out. And at the end of the day, all you're going to be doing is downloading your that you might build for your internal use. Questions on this part of the website? So hearing none, let's go back to the next, because here's just a screenshot of what happens if we select. So again, if we're selecting over here at measures added and we hit the download to CSV, you'll get in this kind of a format. And again, it's basically that same information, but it might be in a way that's easier for your organization to manipulate and digest the data and those kinds of things. So, excuse me. It will give the measure name, your description, the ID, who is the holder of that, and or the steward of that, and specialty measure set that it falls under. So, you know, of the 271. There should be something in there for everyone, right? And if you look at the high priority measures, they're the ones that you would expect would be high priority. So a lot of new information in there. So now you've made your selection. You've got 6 of these things down. You know, using the web interface, I'm just going to make some assumptions here and say we're dealing with a small provider office. You have the readmission measures because, again, you need to have at least 16 clinicians and 200 plus cases. 16 clinicians, 200 is probably not very hard to get to, but most of our practices in South Dakota are going to be smaller than that. So you select those. Now, when you start thinking about scoring on these measures, you receive anywhere between 3 and 10 points on each one of these measures. So maximum you could earn is 60 points, plus there's a way to get some bonus points. But and we'll go through sort of how we're going to get to that 10 points here in a minute. You start out at somewhere between 3 and 10. If you don't submit any performance data, well, of course, you're going to get 0 points for that. We'll talk a little bit in a couple minutes about case volumes and some bonus points and things like that, because I think there are some subtleties here that you may want to spend some time with somebody who has either done this with some people or within your organization, because there's some ways to make sure you're maximizing the points, and I want to make sure you're thinking about that as you pick them, right? So each one of these quality measures can earn you up to 10 points. If your case volume isn't high enough, and in this case for the 2017 year, the case volume is going to be 20 cases. If your case volume isn't high enough, then you can only earn the minimum 3 points. So that becomes really important when you start thinking about amount of time, right, in the year. And our recommendation, while you can go for just 90 days, I certainly recommend that you start that 90 days as early in the year as you can. And if it's going poorly, you can switch to a little bit later 90 days and correct the problem. If it is going well, then you let the clock run and report for maybe 180 days or 270 days. The longer you report, the more likely you are to meet your volume threshold. So you've got to have 20 cases. And in some of these measures for a small practice, trying to get 20 cases in a 90-day period may be really difficult. So it really is important to start this as early as you feel comfortable. So, well, let's talk a little bit more actually about the benchmarks, because benchmarks, there's been some messaging that's come out, especially with the proposed rule, that was kind of cumbersome, and I don't know that it's truly cleared up yet, but it's getting better. Now, depending on how you measure or report, there'll be different benchmarks, not for the quality measures themselves, but in the way the measures are reported. So if you're reporting via EHR, there was a set of benchmarks, say for NGOF 59, the diabetes A1C measure. Then it might be if you're doing an administrative claim. The benchmark will be different. And that has to do with the way that if the far right box here, there need at least 20 reporters in any one of these methods in order to get to a fair benchmark, right? And so it's only possible that if say the consumer survey piece and nobody else does, that benchmark ever meet the 20 reporters that are minimum required in order to set a benchmark for that reporting mechanism. So I want you to be careful about that and think about that as you're going through this list, right? And say, okay, so I'm going to balance the benchmarks with knowing that enough other people do that so that the benchmarks will be met. At least 20 other organizations will be meeting the minimum case volume in this reporting piece. right? So if it's by EHR, which is the way they prefer you to do, I think you're going to have any trouble. But know that that's the case in all of them. So I just want you to be aware of that this is an area where you want to spend some time thinking about it, right? The other couple things about this slide that are pretty important is what the measure is. All practices are going to be combined into one benchmark. So if you're a gastroenterologist and you're doing the diabetes measures, you're going to measure it against all the primary care providers and all the gastroenterologists and all the heart surgeons. So just be cognizant of that too as you get up, right? So because you'll want to be picking measures, obviously, that you could score well in. So do that fit your specialty if possible. Try to balance it against how many other reporters do you think there's going to be. So so the kind of at the bottom there, why does this matter, right? If you happen to pick a measure that doesn't end up with a benchmark, you only get 3 points. So you will never get to the full 10 points on that quality measure if not enough other organizations report on that. So you want to make sure that as we start looking at these measures, you're tailoring them to your practice such that you only just look at what you might be good at. You need to be competitive in a marketplace that's got enough players in it so that you can play on a reasonably level playing field. Right. So about that. I know information just on this one slide. The thing to keep in mind when you're looking at the measures here is some ones that meet your practice, but try to select ones that you think will be relatively common. Avoid that danger of not having a benchmark set for a particular piece. Transition year. Now, again, this is, 2017 is kind of a special year. Didn't measure against a benchmark, right? So that means that a benchmark exists, so that at least 20 other places that are measuring this, and they have the appropriate case volume. If you have sufficient case volume, you've got at least 20 cases. The 200 cases for readmissions, that's that special one we talked about earlier. But maybe you're going to be worried about the 20 cases for a quality measure. And the completeness is met, which means that at least over half of your counters are captured. You'll then be able to reach somewhere between 3 and 10 points, depending on the decile that you fall in, compared to the benchmarks and the other providers that are in that same quality category for that measure. If you can't reach your low volume benchmark, or the benchmark doesn't get made because there's not another 20 organizations doing it, then you're going to get only the 3 points. So again, this sort of affirms the fact that I'd like to see you start early so that you can make sure that you meet your case volume. If until October 2nd and think you're going to do the last 90 days of the year and you end up with 18 cases, best scenario, you get 3 points for that measure. So really try to get your case volume up above 20 as quickly as you can, or as quickly as it works out, but giving yourself more opportunity from a time perspective is the way to go. Number of points, those 6 measures up to 10 apiece, really the only area on this slide, and these slides come from CMS, so that way we're, and they recommend that we use them so that we know we're putting out the same information across the country. We're really only going to focus on the lower right quadrant here, that 60 points. And assuming that most of the people on the call are in provider practices under 15, and so they won't be subject to the readmission measures. So you'll have the 6 quality measures, each one up to potentially 10 points apiece. So 60 points is the maximum you could earn in that category. For the practices on the left-hand side, those that use the CMS web interface, they actually got 15 measures at a minimum, worth 110 points, or if they've got readmission measures, which they probably would, it's based on a 120-point scale. So the vast majority of providers in South Dakota are going to be in that 60%. You can earn some bonus points, and this is an area where I think you have to start thinking about diminishing returns, right? We're looking at the bonus points. You want to try to get the bulk of your points on quality measures that you can get, and only use bonus points to fill in if you feel like your score is going to be not to snuff. So each outcome measure can earn 2 bonus points for. So I don't mean that it's not worth doing, but I am saying that you really need to be cautious about the measures where you could potentially earn 7, 8, 9 points if you're doing well in those, and bonus ones on the ones where you might not be scoring so high on. They could come into play as bonus points, but you won't be maximizing the quality measures to begin with. So I think it's just important that we look at, for your individual practice, how does this play out? And it's going to require some thought and some conversations, and maybe even some outside assistance, say from the Medical Association or the Foundation for Medical Care, or we can help you with it, or you want to be in a conversation with somebody that you're maximizing these points. Right? You also earn a bonus point for submitting through your EHR end-to-end to CMS. That's one point. So if you look at the math here, how math works out, and those bonus points above the line. So if you're scoring, say, 7s across the board on your 6 measures, right? You got 42 points there, plus the 3 or 4 points in the bonus. You see that it's hard to move that very far, and then you divide the whole thing by 60. It's hard to move it very far on bonus points alone. So I think those bonus points are really can maybe get you over the top, but I have a hard time really to maximize your overall points if you're going to rely on bonus points making up for low quality scores. It's just not going to work. So,
say, Dan.
Yes.
Can I ask a question regarding the bonus points?
Sure.
If you pick a measure with hopes of scoring some bonus points and you end up not doing as well as you would like, you actually have points taken away from you on something like that?
No, not on bonus points ones. No. And again, it's mostly marked because it's and this is my current understanding, right? So you select your measures that you are going to be working against the benchmarks on, and then the additionals are going to go through a different scoring structure, so you won't be losing out, say, for example, if you're reporting on a measure that you maybe aren't as well on as you are on some of the others.
Okay, thank you.
So you math, and you basically end up with what percentage of 60 points do I get, right? So if you end up with 54 points total above the line, you're going to get 0.9, and that is so when we get to the final scoring piece, we'll just have 0.9 in mind here. Let's say we did our quality measures. We did fairly well on them. We did well enough actually to get 54 points out of 60. That's pretty good. So That gives you 90% of the maximum points that you could earn in this section. So I'm going to turn my attention here a little bit to picking your own pace. So we talked about this last week, or last time we met. We'll talk about it a little more now because there are 4 options here essentially for this first year. Obviously, the one on the left-hand side I don't want you to take, because if you don't participate 2019, you will get a 4% payment adjustment to the bad on all of your Part B payments. That's the way that's going to work if you choose not to participate. One of the reasons why they're doing it that way is because if you look at the next category over, to get a baseline score, all you really have to do is try. The bar is pretty low, and by pretty low I mean if you submit one quality measure, you'll get 3 points, and that gets you to the bar to get 0% adjustment. Be straight up on the physician fee schedule in 2019 if in 2017 you submit at least one quality measure. The options are as you submit more, right, as you submit your 6 quality measures and your improvement activities and your meaningful use measures, you get to earn a larger percentage of that adjustment. So you could potentially earn up to a 4-point, plus there's a bonus round in there. This question quite a bit. Technically, the difference between the partial year and the full year, there is no difference. If you can get your case volume, because the partial year is you have to submit for 90 days. If you get your case volumes above the minimums of 20 for one of your 6 quality measures in that 90-day period, it would be the same as submitting for the full year. The reason is that most practitioners aren't going to be able to do that, right? So the reality of submitting for a full year, the chance of you getting maximum points is increased because of the volume thresholds. Specifically for the quality category, what the transition year means, that testing of your pace, that day one measure 2017. So if you submit one measure through claims, through your EHR, through any of the mechanisms that are available to you, you will get 0% adjustment, right? And so specifically then, if you at least 6 measures, with one of them being an outcome measure, it is here for the full year, but you don't have to do it for the full year. You can do it for a partial year, as long as you can meet the threshold requirements, the volume thresholds. So you're in 2017. We don't know how long they're going to hold. If 2018, if they change that, which I suspect they'll change it some, I don't know if they'll get to the full where they were with the proposed rule or not, but I wouldn't expect to keep as low as it is for 2017. So when we're calculating the final score, now the last couple of times we met, we talked about clinical improvement activities being 15% of the score. We talked about advancing care information, which is the old meaningful use program, being 5% of the score. And tonight we're covering the final part of the actual pieces that are in for 2017, because the cost category is a 0% value. But the quality measure is 60% of your score, right? If there's 60% available out of the 100 and you score 90% of that, of course, then that would translate directly to a 54 plus some potential of 25 plus some potential of 15, all adding up to what's potentially out of a score of 100. And that actually does become kind of important, as you'll see on this next slide, because here's one of the cases where, you know, you might have a good opportunity to tap in. I think the latest thing that I've seen now is about half of the providers have said they aren't ready to do a full year. It may be a little bit higher than that, and of those that are ready, they don't think they're going to be able to do that on all the measures, right? I mean, they think they're going to be able to do it. So if you're ready, you may be able to get into that additional performance threshold, in which case, if you're above that score, then you can tap into an additional positive adjustment factor. They're going to put about $500 million into the program every year, so exceptional performers can tap into that. The real thing to be thinking about is if you score above that number, and that for 2017 the magic number is 70. Right? If you score over a 70 out of 100 possible points into that bonus round, I guess is the way to think about it, automatically gives you another 0.5% bump. And then there will be some further winners as you get closer to 100 out of 100. They'll earn additional incentives. But by getting to 70, you increase from 4 to 4.5% immediately. A 0.5 percentage point is it's something if you're hovering in the high 60s, or, you know, I mean, it's designed to push you a little bit to try to get to 70. We talked about it earlier. The minimum bar, the performance threshold that you have to meet to get to that zero adjustment is 3 for this year. So as you can tell, there's plenty of ground between what you have to do for zero adjustments and what you have to do to earn that additional 4%. Though if you don't report, you're going to take a negative 4% adjustment. So we definitely, I mean, obviously we want to see as providers pushing themselves as they can, but realistically it's a decision that you have to make as a provider. You know, where do I fall on this spectrum? So we talked about it. I think we talked about it a little bit the last time we met, but we'll talk about it some more now, and then we're going to have to wrap up pretty quickly here. But there are multiple options for you to be able to report. You can report as an individual with your NPI, and report as a group, and that's where if you or a group of you have assigned their billing rights over to a single TIN, then you would be doing as a group. If you're in an alternative payment model entity, you would also be reporting as a group. But their advanced APMs are really not subject to MIPS. They get a 5% across-the-board bonus. So we want everybody ultimately in an advanced APM, but for the time being, how you determine, and again, this is a spot where I'd like you to think about this, because there may be situations where it makes more sense to do individuals as opposed to group reporting. So your data to CMS, and this is another area where there is still some gray, I would say. And if you're an individual or if you're a group, you can look at the chart here. You have different ways of being able to submit your data. So in the quality field, you can do that through a QCDR, Qualified Clinical Data Registry. CMS has a listing of organizations. Most of them are sponsored by different medical societies or specialist societies. And there are also some other organizations that act as these types of data registries. Some measures have their own registries already, and if those are a qualified registry, you can measure through there. You can measure through EHR, you can measure through claims. I think care information and improvement activities, again, there's these different types of measures. And then I guess I want you to take away from this slide is you may measure your quality category by going through a qualified registry or clinical data registry and do advancing care information through your EHR vendor, or be doing improvement activities at a station. In fact, it's very likely that you will be doing improvement activities by attestation, because those are things that are yes, no kinds of answers. Do you belong to a practice transformation network? Yes or no. Do you 24/7 access? Yes or no. So we know that improvement activities will likely be through an attestation process through a website somewhere, but you can mix and match these data reporting pieces. So because you're using one method to report quality doesn't mean you're going to have to do that for all the other ways to get in there. This table shows what that chart was the last couple slides back. If you do anything, you're going to get a 4% negative adjustment, and that would be in 2019 on all your Part B charges. That neutral payment adjustment, which means you reported at least one quality measure or did one improvement activity or did the core of advancing clinical information, you would get a minimum of 3 points, which gets you to that 0 line. There's that big area then between 4 and 69 where you're going to get maybe some performance adjustment, but not going to be necessarily all the way up to 4 points, and it wouldn't be eligible for those bonus dollars. Get above 70, which is where we'd love to see everybody, you not only get that positive adjustment towards the top of it, but you also get an automatic 5% and then, or 0.5%, excuse me. You get additional 0.5%. The eligibility maybe even to have earned more. So now that's the kind of the gist of what I have for tonight. There are some things I think you want to think about here, and I'll apologize for CMS's mattering of the English language here. You'll determine your eligibility status. You'll want to try to figure out how ready am I to go on January 1. You decide if you want to report as a group or if you want to report as individuals. You'll decide if you're going to work with somebody as a data intermediary, like one of those clinical quality registries, or if you want to submit things straight up. And the deadlines, your submission options, you know, try to decide whether you're going to try to get into those bonus categories or not. And then in 2018, assess your feedback and prepared for the additional 4% you might earn in 2019. Last slide. So happy to take any questions at this point. We have about 5 minutes.
Say, Mark, and if I could, I did want to ask things. One, is there a tool out there, or you had mentioned that KHIT's available, you know, how could a provider go in and do an assessment and some tests on the different quality measures so they can figure out which ones would be good fits for them? That's my first question. And then the second follow-up I was going to ask is if you could touch just briefly on that value modifier that you said will not be a factor in 2017, but will be in play by 2021.
So the answer to your first question is if you're in a small organization, only take advantage of all of the resources that are out there. CMS is, like I said, put a lot of money into practice transformation. Next, you contact me directly. There's also QPP SIRS, it's called, Quality Payment Program, small and underserved settings. That hasn't been announced yet, but it's likely to be announced in January. So there's some additional information you can go to there. the industry site called SA Ignite, and a good return on investment calculator to kind of help you try to figure out maybe where you should play. You'll have to work with somebody likely, either somebody in your quality department or have somebody come in that can help tease some things out of your EHR to see how yours come across. I mean, a lot of these measures, you know, people have been reporting PQRS, so those could be the same. To your second question, value modifier, I don't know exactly what that's going to look like when it comes back into play. And I guess I'll just be brutally honest, Mark. I don't know a lot about the value modifier, so I apologize for that. Find out and have an answer ready for you for the next presentation.
Not a problem. I just thought, you know, since it's out there, it's good for folks starting to think about it. So.
Right. Yeah. Like I said, I'm not sure how they're going to bring it back into play. You know, I think the way it's, well, I better not touch that. I don't want to say something wrong.
We're coming up on the hour here. Any other questions for Dan? Oh, no questions so far, but of course you put your contact information out there, and of course I would say that attendees are more than welcome to contact the SDSMA. We can try to answer questions, or for the most part we can certainly put them in touch with you and your team if they have any follow-up questions. The other things before we close for this evening?
I appreciate it. Appreciate the time you've all taken. I know these are your evenings as well, and I'd like to have happy holidays to everybody and Merry Christmas, and I think it's acceptable to say. So, Christmas all.
And we're very thankful for you taking your time out of your evening and your busy schedule to work with us to put these programs on. A few closing remarks. Again, I do want to thank Dan for taking his time with us. This evening, the fourth and final program scheduled in this series is scheduled for Thursday, January 12, 2017. And that topic of the discussion will be the merit-based payment system, or MIPS, performance categories and scoring. So I want to mention anybody that's interested in the Category 1 CME credits are available through the area help. And if it's not, you should be redirected to their website where you can register for those credits. No parting questions. Again, I want to thank you all for taking your time and wish you all a happy holiday season.